talking about the collaboration between the Japanese hospital, which is Sano Hospital. Actually, Sano Hospital is a specific gastroenterology hospital, which is not very common. In Thailand, we have the skin hospital, we have the eye hospital. We not yet have the GI hospital. But this hospital is the GI hospital in Japan. And we start the collaboration because I think in the previous 3 to 4 decades, the gastroenterology education and development a little bit changed because most of the technology and most of the beneficial research come from Japan. The Doctor Society in Japan, they consider the gastroenterologist as one of the biggest subspecialty. So in Japan right now, I think they have maybe more than 35,000 gastroenterology in the country. And there are many cancer centers that deal with the endoscopy. So right now, most of the new technology in terms of the machine or the accessory or the new technique in terms of the endoscopic management comes from the Japanese side. And actually in Thailand, we have quite limited number of the gastro. But I have to inform that the one who can do the colonoscopy could be the surgeon, or it could be the gastroenterologist who is the internist. The gastroenterologist in Thailand, I think not more than maybe 1,000. So it's quite limited. But the surgeon has a much more number. But the way that we train is a little bit different also. Anyway, when we collaborate with the Japanese, one thing that we learn is that we learn the systematic approach. Because one thing when the collaboration allows us to have the exchange with the doctor in Japan. So many of our staff visited Japan and many Japanese doctors also visited us and have the on-site training. So we look together and then we learn how they perform the procedure and how they interpret the findings on the endoscopy and the new technology and new technique. The thing is, one thing that we learned is that the Japanese GI society, they don't do a solo practice. They have everything in consensus. So in Japan, mostly the approach will be the same all over the country. So the way that they do the gastroscopy, how many pictures have to be taken and which picture has to be put on the report, and how to interpret the findings on the endoscopy. This is quite standard, which is a little bit different from the way of the training in Thailand. And the second thing is that because the Japanese gastroenterologists will be very concerned for the endoscopic findings and interpretation. So they try their best to see and to be able to read the tissue, which is, it seems to be like, oh, you just get the tissue diagnosis. But actually, in the medical practice, it's quite important to know what exactly we are doing. So if you know diagnosis more accurate, you can do a better treatment or you can choose the better treatment option for the patient. So this is the thing that we can also learn from the Japanese. There are some new technology, like we call the surface pattern reading. It means that when we see the polyp, we use the button on the machine to use the color to change on the pit pattern or to see the mucosa, which is differently from a simple visualization. And then we can interpret that this is the non-significant lesion, or it's the benign polyp, or it's early cancer, or it could be the deep cancer, something like that. And also we have a chance to learn the new technique to remove the polyp. Before, we believe that the colonic polyp can be removed when it's below 2 centimeters. But right now we learn that we can remove even the whole circumference of the colon by a special technique that we call the endoscopic submucosal dissection. But this is not like anyone can do that. You have to go for a specific training program. And this is a good chance because before we don't have the special doctor who perform this kind of procedure in Thailand. So after we collaborate, we set the training program for our doctors. So few of our doctors attend that training. which actually it takes 1 or 2 years. From starting with the animal model, change to live animal models before we start with the patient. And up to now, we started to perform in the real patient, and the outcome is still okay. For the collaboration with Sano, we start in 2012. So actually up to now, it's about 8 to 9 years. The standard colonic polyp detection, or when we do the colonoscopy for a colon screening, that is the term that we call adenoma detection rate. It means that how can you detect the significant polyp in the patient who come for the colonoscopy. If the number is high, it means that you are good for the colonic polyp detection, which means that the quality of the overall colonoscopy is good. That is the standard, which is acceptable universal number of 25. When we firstly started, I think we around 30. Right now, the number of the colonic polyp or adenomatous polyp detection, or we call adenoma detection rate right here, is about 50 to 60% by average. So actually it's more than average. But one thing that we do which gonna improve things in our unit a lot is that we do an individual monitoring. So actually, I mean, as the one who is the head of the unit is quite strict for that. So we have to do annual personal performance evaluation. So I have to review my colonic polyp detection, adenomatous detection rate every year. And in these past 3 to 5 years, everyone keep improving. So this is one thing that I think we can tell the patient that, oh, if you come here, you're gonna have a good quality of colonoscopy, and not much things gonna be missed. There are some other things that we also can do to control the quality, like some kind of colonic procedure preparation, which we have a very good system for that. And also we monitor the time of the doctor to perform the procedure. If you do it too fast, it doesn't mean that it's good. If you do it too slow, it's not good as well. So it has to be the optimal time. For our staff, we have totally 11 full-time right now. We have another about maybe 15 part-time doctors. So average about 20-something gastroenterologists. Actually, just the full-time will be trained in the system, and we don't involve much with the part-time doctors, but most of the part-time doctors come from the university hospital. So I think we can rely on them also. Actually, I started working in this hospital about 15 years ago for just the colonoscopy. Okay, we're talking about the colonoscopy. Before, I think it's about 1,000 per year, less than 1,000 per year. But right now, approach 3,000 or 3,200, something like that. So actually, the number increasing quite a lot. And regardless of the patient will also be recommended by the doctor, because right now the colon screening is one of the most important thing that most of the doctor who take care of the patient as a primary physician or some other subspecialty should know that their patient should have a colon screening. So it will be more recommended.